Nasopharynx tidbits. So first, WHO classification. WHO grade 1 is generally caused by tobacco and alcohol use. It's keratinizing. It is the most common type in the United States, so the way to remember this is USA is number 1 because we drink and smoke. WHO grade 1 nasopharynx has a lower overall survival, more advanced primaries, but fewer nodes involved, and it is not EBV associated. WHO grade 2 is non-keratinizing and differentiated, so as opposed to number 1, or WHO 1, which is keratinizing. WHO 2 is non-keratinizing, it is differentiated, and it may be EBV associated. And then WHO grade 3 is, again, non-keratinizing, undifferentiated, and is EBV associated. It's the endemic form. It's associated with better local regional control, but more distant metastases. Lastly, basaloid, which is non-WHO type, is aggressive and has very poor survival. The anatomy of the nasopharynx that you need to be aware of. The torus tuberous is the lateral eustachian tube orifice protuberance. Rosenmuller's fossa is posterior to the torus tuberous, is the most common cancer location. The pterygopalatine fossa connects with the masticator space. And the foramen lacerum goes into the middle cranial fossa and the cavernous sinus, so it is a portal for intracranial spread. Cranial nerve foramina levels, nerves 3, 4, V1, and 6 exit through the superior orbital fissure, 3, 4, V1, and 6, V2 through the foramen rotundum, V3 through the foramen ovale, 7 and 8 through the internal auditory meatus, 9, 10, and 11 through the jugular foramen, and 12 through the hypoglossal canal. Here's a picture here of the foramen rotundum, which is kind of near the little clinoid processes. Then the foramen ovale, which is kind of oval-shaped, and then the foramen lacerum medially and the foramen spinosum laterally. Cavernous sinus contains 3, 4, V1, V2, and 6. 3 through 6 with the exception of V3. Workup. Extra workup, H&P with attention to epistaxis and cranial nerve palsies, trismus, and notalgia. Labs, EBV viral load. This is predictive and prognostic. An MRI of the primary and the base of skull. Positive cranial nerves to the base of skull. Or plus the cranial nerves to the base of the skull. PET CT for all patients. Symptoms of concern, jugular foramen syndrome or Villarette syndrome. Parapharyngeal space invasion, which affects cranial nerves 9, 10, 11, and 12. Jacquard's syndrome is cavernous sinus invasion affecting cranial nerve 3, 4, 6, V1, and V2. Again, there's no V3 in the cavernous sinus. Villarette syndrome is compression of cranial nerves 9 through 12 by the parapharyngeal nodes. Trismus is a marker of masticator space invasion. If initially elevated, follow EBV titers during surveillance. The most common nodes are the retropharyngeal, levels 2, levels 3, and level 5A. 5A versus 5B. A is superior to the bottom of the cricoid. B is inferior. Note that this is different than deep 5. It corresponds to low neck for nodal staging purposes. See end stage box. T staging, the 8th edition. T0 is no primary but EBV positive cervical nodes. T1 is confined to the nasopharynx or with extension to the oropharynx or nasal cavity without parapharyngeal involvement. T2 is parapharyngeal extension or adjacent soft tissues, including the medial or lateral pterygoid muscles, the prevertebral muscles. T3 are bony structures like the skull base, the cervical vertebra, the pterygoid structures, and the paranasal sinuses. T4, intracranial extension, cranial nerve palsies, hypopharynx involvement, orbit involvement, parotid gland involvement, extensive soft tissue beyond the lateral pterygoid muscle. End stage, N1, unilateral node or any retropharyngeal nodes, including bilateral retropharyngeal nodes that are less than or equal to 6 centimeters. N2, bilateral nodes less than or equal to 6 centimeters above the cricoid, with the exception of retropharyngeal. N3 is greater than 6 centimeters or below the cricoid. Overall stage, T1, N0 is stage 1. T2 or N1 is stage 2. T3 or N2 is stage 3. T4 or N3 is stage 4A, and M1 is stage 4B. Easy way to remember this is like pretty much the T stage corresponds to the overall stage, and then the nodal stage starts at 2 and goes up to 4A. In terms of management, a T1N0 gets treated with RT alone. 3-year overall survival is 90 to 95%. Chemo is controversial in early stage. For T2 to 4 or any node-positive tumor, the treatment is concurrent cis radiation and then adjuvant cis 5FU times 3 cycles. The concurrent dose is 100 milligrams per meter squared every 3 weeks. The adjuvant dose is 80 milligrams per meter squared plus 5FU, 1,000 milligrams per meter squared over 4 days, every 4 weeks times 3 cycles. This is the intergroup study chemotherapy. The exact value of adjuvant chemo is unclear, omitting this as category 2B per NCCN. You can also consider induction chemo followed by chemoradiation, which is category 3. M1 disease gets chemoradiation or chemo alone. Both are 2A recommendations. Evidence intergroup 0099 al-Saraf. Chemoradiation plus adjuvant chemo versus just radiation alone is what this is all about. This is 193 stage 3 or 4 M0, which is currently T3 or N2 with current staging, including T2. They were randomized to 70 gray versus 70 gray plus concurrent cisplatin times 3 cycles, followed by adjuvant cisplatin and 5FU times 3 cycles. So largest increase in 3-year progression-free survival ever, 69% versus 24% for 3-year progression-free survival. The trial was stopped early due to this 30% increase in overall survival. Overall survival at 3 years was 78 versus 47%, and at 5 years was 67 versus 37%. So again, 30% increase in overall survival. Criticism with this trial was that local control was poor in the radiation alone arm. 22% of the patients had WHO grade 1, which isn't really applicable to endemic disease. It was really poor tolerability. Only 63% completed the concurrent chemo with the cisplatin, and only 55% completed the adjuvant chemo. Subsequent meta-analyses show that concurrent chemo adds approximately 5% improved overall survival. Trials looking at the role of IMRT. The biggest one here is RTOG 0225 Lee. Single arm phase 2 of stage 1 to 4B. Nasopharynx cancer. IMRT was 70 gray or 59.4 gray in 33 fractions. I shouldn't say or, I should say and. I presume the 70 gray was a concurrent boost or simultaneous integrated boost. For anything that was T2B or greater or node positive, they got concurrent cis and adjuvant cis 5FU. The 2-year local regional recurrence rate was 13%, and 2-year distant Mets was 18%, which is staggeringly low. The late xerostomia rate with IMRT was 14%. The bottom line from RTOG 0225, Nancy Lee's trial, is that outcomes with IMRT with SIB were improved over intergroup 0099. The role of induction chemo, Sun et al., Lancet 2016, TPF induction, then chemoradiation versus chemoradiation alone with no adjuvant chemotherapy. Induction increased overall survival. No, we don't know if we really need adjuvant chemo. This is the subject of an ongoing trial. There's a first affiliated hospital of Jinan University, Guangzhou, China, JAMA Net Open 2019 meta-analysis of 28 trials to evaluate the role of neoadjuvant, concurrent, and adjuvant chemo. The bottom line from that meta-analysis is that induction chemo and concurrent chemo improve overall survival, progression-free survival, distant Mets, and MRC. Adjuvant chemo does nothing and should be avoided. The MAC-NPC PEDIT ASCO 2020 was a meta-analysis of 28 trials and showed no overall survival benefit to concurrent chemo, no benefit to adjuvant or induction chemo. Sorry, there was an overall survival benefit to concurrent chemo with the MAC-NPC meta-analysis, but no overall survival benefit to adjuvant or induction. In terms of technique and planning, SIM, supine, aquaplast, mask covering the shoulders, CT with contrast, and fused MRI. Planning, IMRT is 33 fractions. Alone, local control is 90%. A dose, And 35 fraction should be 70, 59.4, or 54. Again, 33 fractions. Volumes, GTVP and GTVN using the fused MRI. Nodes are positive if retropharyngeal is greater than 5 millimeters or others greater than 1 centimeter. The CTV70 is GTV primary and GTVN with a 5 millimeter expansion. Note, minimal expansion is 1 millimeter if it's close to a critical structure. CTV 59.4 is your GTV primary plus 1 centimeter and GTV node plus 1 centimeter. You can shrink 2 millimeters off the GTV if it's close to a critical structure. It includes the entire nasopharynx. The anterior border of the nasopharynx is the posterior quarter of the nasal cavity and the maxillary sinus. The posterior border is the anterior third of the clivus if no invasion, or the whole clivus if there's invasion. Superior border is the inferior half of the sphenoid sinus, or the entire sphenoid sinus if we're talking about a T3 or T4 tumor. And the inferior border is the soft palate. Skull base, you want to cover that, including the foramen rotundum, ovale, and lacerum. You need help from the radiologist probably to identify those. The pterygoids, the parapharyngeal space, and the first echelon nodes, which would probably be bilateral retropharyngeal levels 2, 3, 5A, 1B if they're actually positive nodes clinically. And the cavernous sinus, the involved side if we're talking about a T3 or T4 tumor. GTV 54 is bilateral 4 and 5B down to the clavicle. You can omit if it's node negative. PTV is a 5 millimeter expansion, 3 millimeter of IGRT, 0 if the CTV is touching the brainstem or cord. Constraints, if you cannot meet the DVH constraints, resim and rescan with MRI at 40 gray to shrink the volumes. All initially involved volumes need to be covered to at least 59.4 gray, but can shrink PTV 70. You can also shrink CTV and PTV margins if needed. Dose constraints, the cord max is 45. The optic chiasm, brainstem should get a max of 54. Parotids mean less than 26. Larynx mean less than 45. Cochlea mean less than 30. Max should be 45 for the cochlea. Pharyngeal constrictors mean less than 50. Esophagus mean less than 34. Oral cavity mean less than 30. Lips mean less than 20. Mandible max less than 66. Toxicity and follow-up, local control, it's approximately 90%. Distant mets are 15%. 5-year overall survival for stage 1 is 90%. For stage 2, it's 80%. For stage 3, it's 70%. And for metastatic disease, it's 60%. Toxicity, acute toxicities include mucositis, dermatitis, xerostomia, and dysgeusia. Late toxicities, there's a 25% risk of grade 3 to 4 toxicity. These include cranial neuropathy, trismus, soft tissue fibrosis, xerostomia, hearing loss, osteoradionecrosis, temporal lobe necrosis, hypothyroidism, hypopituitarism if you're including vasculopathy, and dental caries. You need fluoride trays. Follow-up, you can add an MRI at 6 months to the general paradigm of follow-up for these patients.